to evaluate for hereditary alpha-tryptasemia, which, as you all know, is it's a mast cell product, okay, alpha-trypsin. So there is a condition called hereditary alpha-tryptasemia, where patients have high levels of serum trypsin because of this condition called hereditary alpha-tryptasemia. And if the patient has a baseline serum tryptase level of more than 8 nanograms per ml, you have to evaluate for this very common condition, actually, hereditary alpha-tryptasemia. We don't have Indian data, but in the Caucasian population, it is about 1 in 20. So it is really quite high. And the other thing to investigate for is clonal mast cell disorders. I think I have taught some of you about the alpha-gal allergy, which is again a kind of a newly identified allergy. It is an allergy to the carbohydrate moiety in certain mammalian red meat, which can cause delayed anaphylaxis, symptoms presenting after kind of 6 hours, and can be a difficult thing to diagnose. A little bit of information about biphasic anaphylaxis. So what they have found is that there are certain risk factors which can predict which patient is going to go on to develop biphasic anaphylaxis. So it is associated with greater severity of initial reaction. So somebody who has a severe initial reaction, more likely to go on to have biphasic anaphylaxis. Persistence of reaction, they've needed more treatment to get better. They can have biphasic, using more than 1 dose of epinephrine, obviously, because it persisted. Wide pulse pressure, unknown trigger, cutaneous signs and symptoms, drug triggers in children, and delayed use of adrenaline is the other one. Okay. And the percentage of biphasic is 6.5%. Earlier data had suggested up to 20%. This data is suggesting 6.5%. And the median duration between resolution of initial episode and second reaction is around 10.5 hours. So if we need to monitor these patients, we need to monitor them for more than that for the biphasic reaction. Okay. Identifying patients at risk of anaphylaxis. So this is from 2024, published in the WAO journal. Really nice data is here. So some of the things that you may not necessarily be aware of, certainly I found it a little bit new. I will just go through. Most of it we actually know. So we know that adolescents and young adults are at an increased risk of anaphylaxis. And one of the things that has been highlighted is disease denial and treatment non-compliance. Okay, we know this, but they actually have data for this now. And as people get older in the adolescent age or the young age, the adventurous nature increases, and they may not have been exposed to their allergen for a long time. They feel they have outgrown it, they try it unsafely, and they may have anaphylaxis. Okay. Comorbidity-wise, they have highlighted thyroid disease. Now, this is something that I hadn't seen in the previous literature. And of course, hereditary alpha-tryptasemia is coming up as an important comorbid factor now, mastocytosis also. And in the allergens with increased intrinsic risk of triggering anaphylaxis, food additives is included here, apart from the things we already know, like nuts and milk and shellfish, etc. And inhalants like cat allergen, hamster allergen, horse dander, grass pollen, that has been included in the risk of allergens with increased risk of triggering an anaphylaxis in the latest data from last year. Okay. Other relevant factor is anybody with a previous past severe anaphylaxis. This is a little bit obvious. Viral illness is one more thing that they have added, and delayed or failure to use their adrenaline auto-injector. It is so interesting that even in the developed countries where they have ready access to auto-injectors and they know all about it, they recognize anaphylaxis. A lot of families, I'm sorry, I request all of you to please be on mute. Yeah. So it's so, sad to note that a lot of families may not actually use their auto-injector on time. And that's highlighted as a risk factor. Okay. One more thing I just want to highlight is about the biomarkers. It's just a few more slides now. The biomarkers. So serum trypsin, we all know, okay? And a few important things about serum trypsin that in the latest data they have highlighted is that if the serum trypsin is elevated to more than 20 nanograms per ml, which sometimes it is in both acute or basal sera, diagnosis of mastocytosis has to be considered, okay? And if it is more than 8 nanograms per ml basal tryptase level, we have to consider diagnosis of hereditary alpha-tryptasemia. Okay? And this again we know, but if within normal limits, diagnosis of anaphylaxis cannot be excluded, which is a little tricky for us in terms of diagnosis. And one more data that has come up is total tryptase level can be measured even in post-mortem serum. So even, after the patient has died, we may be able to measure their serum tryptase level if we want to confirm the diagnosis. Okay. And then there are so many other potential biomarkers under research. And that is so nice and so encouraging to see, because as of now, we only had the tryptase. Okay. So they have studied plasma angiotensin 2. Basically, what they have found is low ACE inhibitors have been found in patients with severe anaphylaxis. So that is emerging as a risk factor. Okay. And platelet activating factor is emerging as another biomarker. Basically, it has a very short half-life, which is a bit tricky. 3 to 13 minutes short half-life only, but it is supposed to correlate very well with the severity of the anaphylaxis. So, in future we may have it, but as of now, it is just research. So then other biomarkers like chymase, carboxypeptidase, all these are byproducts of mast cell degranulation. Okay, cathepsin G, prostaglandin F2, so many other inflammatory mediators, emerging biomarkers. Okay, so total serum tryptase we know. So in the interest of time, I'm going to skip it. And I want to highlight this particular thing, which I found very fascinating, is that if we think about, why some person with the same food allergy gets a mild reaction, whereas another person gets a severe reaction, or the same patient on one occasion gets a mild reaction and another occasion they get a severe reaction. So you can see how you need a lot of things to fall in place for them to get a severe reaction. Okay, whereas if there are some things that are blocked, they may end up getting a mild reaction. And some of the important things to be highlighted are things that we already know, but allergen presentation, large dose of allergen, more likely to cause a severe reaction. Host immune response, host behaviors, burden of allergic disease, and like asthma, if the patient is uncontrolled asthma, more likely to have a severe reaction. Medications that the patient is on, like beta blockers. Other host factors, like, are they menstruating? Are they sleep deprived? So many other things, okay? Intrinsic ability to compensate. We all know that a lot of anaphylaxis self-resolves. How? It's by our own adrenergic mechanisms, okay? But there may be occasions when we are able to compensate if everything is well, whereas there will be other times when we are not able to compensate, okay? And of course, delayed treatment or inadequate treatment. So, what we want to do is try to maintain our patients always in this mild reaction category and not allow them to go to severe category. Okay. Genetics, very, very fascinating, but I'll just cover a couple of things. It's a very large topic, but because we now have genome-wide association studies, there are a lot of genetic markers which are emerging, suggesting elevated risk of allergy and anaphylaxis. Okay. So one really interesting thing is a particular HLA allele for wheat-dependent exercise-induced anaphylaxis. So it's a fascinating condition, and we always wonder, why is this person susceptible to, who is actually tolerating wheat? Why do they get susceptible to wheat allergy when they have exercised only? Okay, and there is a genetic basis for this, and there is so much more that is being discovered. The other thing in the genetics I want to highlight is hereditary alpha tryptosemia. Okay, it's an autosomal dominant genetic trait studied in the Caucasian population. We don't have Indian data. 1:20 of the population is actually affected by this particular genetic trait. Okay, and these patients have elevated basal serum tryptase level, and they are more likely to get anaphylaxis or serious reactions. But not everybody with this trait gets anaphylaxis or serious reactions. Why that is, we don't know. Okay, but I'm sure with so much emerging data, a few years down the line, we may have this information too. Okay. Role of component resolved diagnosis. Many of you are aware of component resolved diagnosis. So we know that here we are able to actually test for specific IgE for particular component. And why is it important in the context of anaphylaxis? For example, in the context of peanut allergy, if somebody has specific IgE to ARA-H2, which is Arachis hypogea 2, which is a particular component of the peanut protein, then this is a marker of severe anaphylaxis in peanut allergy. Okay, so if the patient has some kind of a reaction to peanut and we are not sure if this patient is going to be at a risk for anaphylaxis, this is something that we can do so that we can predict that this patient has a severe risk, which means they have to be extremely vigilant, complete 100% avoidance, and have access to an auto injector. Adrenaline of some form, they should have access to at all points, and with the appropriate counseling and management plan. Okay. Now, last but not the least, this is almost one of the last slides. This is data from this month, July 2025. Okay. So here they have looked at risk factors for fatal and near fatal food anaphylaxis. So this is only food. The previous data I showed you was all cause anaphylaxis. Here it is food anaphylaxis. Here, what just the important highlights is that asthma is a very important risk factor. Okay, we know this, but they have very robust data to prove this. Peanut as a culprit food, and also cow's milk. Okay, so we have to be ultra vigilant about our peanut allergic patients, and cow's milk is also emerging as an important risk factor for fatal and near fatal food anaphylaxis. Okay, and this is increasing. So this is a bit scary because in India we know that cow's milk protein allergy is definitely increasing. So we have to be vigilant. Okay, and amongst the foods we know peanut, cow's milk, so many others. And place for anaphylaxis, they have very large data to support that the place where it happens is home. The other places are restaurant, school, outside. Hospital is only 2%. Okay. So the patient is actually having an anaphylaxis when we are there as doctors in front of them is just 2%. The rest of it is happening outside their home, outside the hospital. Okay. In their home or other places. So hence the importance of having access to adrenaline, so much education, etc. Okay. Now, again, to highlight that FDA has approved use of omalizumab just last year for patients who have severe form of allergy, particularly risk of anaphylaxis to trace amounts or accidental exposure to allergen. Okay, so whether it is one food or multiple foods, omalizumab can be used in children more than 1 year of age. Okay, and here this is a study where they have actually studied for the treatment of multiple food allergies and found that the threshold of tolerance increases to the food that the patient was previously severely allergic to. Okay, so this is quite encouraging that we can use omalizumab in our severe allergy, food allergy patients. Okay, and some of you may know that FDA has approved the first nasal spray for treatment of anaphylaxis. So it's called Neffy, and it was FDA approved last year. There are 2 doses that are available. It's an intranasal spray. It comes in a pouch like this where there are two different doses so that the patient can use 2 doses if required. So one spray has just 1 dose. 2 milligram is what we use for more than 30 kgs. And 1 milligram is also available, which can be used for over 15 kgs or over 4-year-old children. Okay, it's not licensed for use under 4 or under 15 as of now. So this is what is available. It's not yet available in India, but it's extremely useful, and studies have shown equal efficacy as compared to intramuscular injection of adrenaline. Okay. And I just want to highlight our own Indian product, which is being developed but is awaiting manufacturer license. So in 2022, they actually got the James Dyson Award for their innovation. So EpiShot it's what it's called. It's an indigenously developed adrenaline auto-injector, which is reloadable. And it was developed in Indian Institute of Science in Bangalore, but they don't yet have the license for manufacture. So I hope that will happen soon. Okay. So take home messages, I think I have highlighted, and you all know this. I'm sure you can tell me it all, but make sure that early intramuscular adrenaline, and please teach your colleagues, teach your staff. A lot of you are in medical colleges, teach your students, recognize patients at risk, and be education for the patient. I can't stress enough. Okay. And you all are aware that there is a gap module that you can all access. All of you can access it on the Medtrain app. Anybody can access. You don't have to be an alumnus of Medtrain. Okay. So with that, I think I will stop my screen share. Thank you all for your patient hearing.
Thank you, Dr. Nandana. That was an excellent talk. And the way that you always go through the literature research is something amazing. You actually give us the gist of it. I have just one question, and then I leave it to Dr. Bala and the other faculty and keep the the forum open for questions. There are some interesting questions in the chat box also. Is there any update on obese patients? Do they differ in the response? Often, especially when we give an indigenous preparation, we put a 26 gauge needle. So I'm at times scared whether that will just end up as just a subcutaneous route for them instead of intramuscular.
Yeah, so that is a very valid fear, and it's actually been studied. And particularly in the context, we all know that with the auto injector also, the needle length may not be enough for obese patients. So there is one particular auto injector that comes with a longer needle for obese patients. So I think when we are giving them our indigenous device, we need to be aware of the amount of subcutaneous fat and probably give them, the longest possible needle. The usual 26 gauge or 24 gauge needle may not be sufficient for these patients. But exactly how much to recommend, I think it's difficult to say. Yeah, but we definitely need to consider that. So a very valid point. Yeah.
Yeah, no more than 26 gauge or 24 gauge, it's the length of the needle.
Length. Yeah.
Length of the needle rather than the gauge.
Yes.
Absolutely.
Only
Yeah.
the 1.5 inch is
1.5 inches, yes.
what we need to. 1 inch is what is a subcutaneous one. 1.5 inch generally perpendicularly is what we should recommend, and that's what is available also.
Yeah, and you can stretch the skin, press the skin and stretch it so that you're more likely to go intramuscular. So 1.5 inch needle and stretch and give and hope that it's intramuscular. Yeah.
Dr.
I
Nandana,
think also pressing it when they do it perpendicularly and pressing it in to make sure it goes as deep as possible.
Yeah. Yes.
some questions are there, Nandana. You can see the questions, right?
Yeah. Yeah.
Dr. Mawsam is asking, is it the same drug with two different names? What
Which one?
I think Dr. Mosam has replied. Somebody has asked whether epinephrine is the first choice or adrenaline.
Oh,
Okay.
okay. No, it's the same name, same
so
drug,
Dr.
different.
Mosam has
Yeah,
replied to that.
Yes, yes, yeah. So epinephrine and adrenaline are just words used in different countries, so they both mean exactly the same thing.
Yeah. Someone's asked how late will adrenaline be effective? So I think the question is till how long can you give it, or how long
Yes.
after it starts can you give it?
Yes, so obviously we have to give it as early as possible. But if the patient is in front of you and it's been a while, they're there, they're alive. You please treat. Okay, so you have to give the first dose and see, and then you follow the protocol. May need to give a second dose because it's late treatment. So these patients more likely to need a second dose. But please treat. Okay, it may be effective. In fact, it will be because the patient has somehow managed in the last half hour or so. So yes, please give.
Better to treat and find out whether it is than wait and not.
As long as the patient is symptoms and not received adrenaline, go ahead and give it.
Treat it. Yeah.
So
Definitely.
whenever there is the benefit of doubt, always error on the giving rather than holding back.
Yeah.
Yes, yeah.
Even
And
sometimes
actually, what I have not included here, I should probably do that, is the fatality data. So, if we know that patients who are going to die of their anaphylaxis are going to usually die very soon after the exposure, okay? So, the very fact that, the patient is, alive after a while, means that you can treat and the patient will probably get better, okay? So, go ahead and treat, full treatment, however late it is, yeah.
if the patient has angioedema, orbital edema, tongue swelling, but BP is 100/60, uneasy but saturation is 99 after brufen use, since it is not full-blown anaphylaxis, will you advise giving hydrocortisone? Yeah. I mean, maybe the question was supposed to be adrenaline or hydrocortisone. I'm not sure, but what is written is hydrocortisone.
Yeah, so I think they mean that because it doesn't fulfill the anaphylaxis definition criteria, we will not probably give this thing. But see, tongue swelling, may cause airway closure. Okay, it may cause airway obstruction. So be cautious, and especially if it's progressing, I would give adrenaline actually.
You wouldn't harm them by giving adrenaline. So I would say always err on the side of caution and give it.
Yeah, definitely. Yeah. So here I would give tongue swelling. I would give. Here, the only thing is whether this may not be anaphylaxis. This may be even
Yeah.
like a other angioedema, like a bradykinin-mediated angioedema. So you need to be careful there because adrenaline or steroids will not work over there.
I think the other part of that question
Rapidity
is
it started. What rapidity things started, and after how many minutes or hours you are seeing the patient, that will give us a clarity and idea what we are dealing with that.
I think the other part of that question is, would you also give hydrocortisone?
Yeah. So hydrocortisone, see, as of now, the WHO criteria, the guidelines says about giving it as a second line treatment. Should never delay giving the adrenaline. You should give it later. Okay. And so as of now, I would follow that. Okay. But it may change. The guidelines may change. So it's a space to watch. So here I would give hydrocortisone if I think that it is an allergic reaction, a mast cell mediated and not bradykinin mediated. I would give adrenaline. I would also give hydrocortisone. Okay.
Is it possible for people having food allergy for vegetable or angioedema for vegetables containing seeds like cucumber, capsicum, brinjal?
Yes, it is. Yeah.
So
In
I think
theory,
essentially question
yeah.
is, can you have anaphylaxis to these kind of vegetables?
Yes. In theory, any food can cause it. It's not very common, but anything can cause. Okay. So seeds, particularly, are known to cause, allergies, and even anaphylaxis can occur, but we don't see it that commonly. It can happen. Yeah.
Yeah. If you're not sure of a particular insect, but you know that anaphylaxis is due to insect bite, what do you do?
Yeah. So then in the acute management remains the same, isn't it? So you will have to treat it acutely, get the patient better, and then you will need to investigate. So now we have tests to test for the various insect venom. So you even have component resolved diagnosis, which can test for the individual venom. Or you can do separate specific IG if you have some kind of a idea which insect it might be, and then you can talk to the patient about prevention and then consider venom immunotherapy if indicated. Yeah.
So the next question, I think it's a three part. So if somebody has only tongue swelling, would you still need to give adrenaline is the question. So essentially they're saying all other parameters are normal following ingestion of a allergenic food. There is only tongue swelling and nothing else. Would you still need to give adrenaline?
Yeah. So I would see how this swelling is affecting the patient if it's progressing. If I feel that they're finding it difficult to swallow, if they're finding that lump in the throat sensation because the tongue is swelling, that means the airway is about to close. You would definitely treat as such. And also think about early airway protection in these patients. Get your anesthetist in, get them to have be on standby, have everything ready. It can be quite dangerous and difficult to manage. So yes, treat.
And that's all the questions there are. We had almost 100 participants at one point.
Yeah,
it's a very good turnout.
Big number. Yeah,
So, Dr. Nandana, that was an excellent presentation, very, very clearly elucidating the whole of, management of
Thank you.
anaphylaxis, all the latest guidelines and everything. So just to add to what you said, not add actually, just highlighting, you said that the awareness in the Western world is so high. Just as an example, my daughter who works in London, she works in a consultancy firm. It's a big firm, over 2 floors. And recently they were told that a new employee will be joining who has peanut allergy. So they have banned all employees from getting any kinds of nuts to the workplace for lunch, or basically there's nothing available in their cafe, in their kitchen. And they've also told, so even not just ingestion, they're even looking after the airborne particle that's possible. So I mean that's a long way away from where we are, but if we can make a dent in the awareness and spread the awareness here, that would be excellent. It's a totally preventable, avoidable kind of fatality. So, yeah, we just need to be aware.
Yeah, that's very, very, that's such a nice thing you've highlighted. That level of awareness is there. and should be there, because you've seen the data how peanut can be a very catastrophic allergen, isn't it? Very small exposure can cause, even aerosolized, like you rightly said, can cause anaphylaxis in some patients. So yes.
I think even if it starts with schools, because children, even if it
Yes.
starts with schools with, things being not, prevented from bringing it to school, I think it's a first step. There's one more question, Dr. Nandana. Um, Following a skin prick test, how many hours do we have to observe the patient to rule out a systemic reaction? So I think they mean that if somebody was going to have anaphylaxis to a skin prick test, how long after a skin prick test might they have it? So how long do you need to observe them?
So anaphylaxis following a correctly done skin prick test is fortunately, almost nil. Okay, it is a theoretical possibility, but it's very, very rare. And if at all you feel it's a high risk patient, you would, after the SPT, you would observe them for half an hour or an hour, and also look at the size of the wheel and flare reaction that you're giving. Sometimes these patients may get very large reactions. So do observe them for some time, but thankfully very rare systemic reactions. They do get, sometimes some of them may have intense itching or intense local reaction. Systemic reaction, very unusual.
Dr. Neelam has highlighted that on an international flight, similar announcement was
Yes.
made regarding a passenger with a nut allergy.
Yes, yes, there have been lot instances of patients dying on the flight, despite 2 doses of adrenaline, and even three sometimes. And so yeah, on a flight, you can't be vigilant enough. So yes.
I think there are some questions which are not related to anaphylaxis also. I'll just ask them anyway because can we do skin prick test with allergens from different companies in the same sitting?
Yes, I suppose if the indication is right, yes, why not? We do that, in fact, isn't it? So sometimes when we are checking for house dust mite allergen, we do use the standardized
Standardized.
one, and some of the other pollen we might use the Indian one. So yes, it can be done. Yes.
I think the important thing is if you're considering immunotherapy, make sure you use the same thing that you have used for skin prick test. So whichever one. And so if you have it from the same company, it's easier to order immunotherapy from the same company for whatever it is, whether it is standardized or non. I think it's more practical issue rather than.
Yes. Yeah.
That's the end of all questions. So, Dr. Bala.
Yeah. No, thank you, Srilant. Wonderful, Dr. Nandana. You have kind of made this, whatever the allergy week theme was, anaphylaxis, and then probably that content is deep driven into that. So it was really wonderful that so many learners had joined it. In fact, we didn't expect that such a huge number will be there. So from nothing from my side, I think you have covered everything. I just wanted to say that, okay, this advanced allergy asthma specialist course is like admissions are going on, and those who are kind of an interested probably can consider that. And second thing is, yeah, what is new from Medtrain is aerobiology course is being on the journey of building the aerobiology course for clinicians. Probably it may take another 3-4 months, and probably we'll be there with an aerobiology course. So these are the two updates from our side. Yeah, and we would like to hear from the doctors, students here, that what challenges they are facing in their practice. Is that, I mean, anybody who would like to unmute themselves and even talk about it, is something that else that you guys are expecting from us as kind of a faculty. It's not like, okay, the course is completed and our relationship is done. It's not like that. We would love to maintain the relationship for longer time, but we would like to hear from you in your real world what challenges you are facing it, or what difficulties you have, or is something that we can you expect from us to build something, or have a session something. So we would like to hear from you so that we can build something which is appropriate for you. And I would love to hear from All of us are allowed to hear from you. Mute or put it in the message.
So you can probably raise your hand if somebody wants to talk, and then you would be able to convey. Yeah. So any practical challenges in practicing allergy, or anything that you face in kind of routine practice that you feel we can help you with, or you can share it with us.
Dr. Mosam has written allergy registry and medical legal support.
Dr. Mosam, I would request you to unmute and also speak on, I would want a couple of our alumni also to speak out on how your allergy journey has been. We keep seeing that, recently we had Dr. Rajendran conducting a allergy week celebration in Rajarajeswari Medical College. Dr. Aditi is doing a lot of podcasts. Dr. Krishnan is doing a lot of social awareness. Couple of you are writing books. It's really so rewarding for us to see that our students are doing so well. So if you all are there in the meeting, I would just want you all to speak a little word on your allergy journey too. And we would also want to engage you all, even in future with such kind of a program, whether it's an allergy week or not, or even if you just want to present a case, we can keep it as a master class. So please approach to us, and please feel free to connect back to us. Dr. Mosam, do you want to speak about it?
Good evening, everyone. Yes, I would. So today in the evening, Gayatri ma'am messaged me that would you like to speak about the allergy practice that you're setting up or that you've set up so far in Mumbai. So yes, I would love to talk about it, and I'll try to keep it short. So I'm Dr. Mausam Maru, and I'm a pediatrician and allergy specialist now working in Mumbai. I have started my allergy center in Thane. It's on my own name. So first of all, I would like to say that I'm really glad that this meeting was organized with all the alumni, all the peers, and the mentors who've been a part of my journey right from the beginning. So, and I would like to give you a short idea on how I finished my master's, and then I did my allergy asthma specialist course and my fellowship course by MedTrain. And then I had gone for my clinical attachment overseas for about 3 months. And then when I got back, I wanted to definitely start my own practice, because one thing I noticed overseas and not in India is that doctors are trained at both the places, but it's the patients who are dodging from one place to the other in India before they actually reach the proper allergy center. So that was my final will, or you can say the passion, that I wanted the allergy patients to reach the right place. And that's how I decided to start my own center. And before I started my center, I came back to India, and I even did a 2-week internship in Bangalore, where I visited Allergy Central, and all the mentors who trained me. I went to each of their clinics to see how they practice, and they gave me their time, and I'm really thankful to them, because I got to know how to set it up in India. It was very different from how it is overseas, where they get all the support. In India, since allergy is not still considered a different specialty, it's always difficult. And when I visited their centers, I realized that I don't have to hunt for allergy centers in Mumbai or other allergy specialists in Mumbai to team up. I can just start it myself. So I really thank all of them for giving me this confidence to go ahead and start it. And my husband, he helped me with planning the center, doing up the whole thing. And when the patients would walk in the initial few weeks, so the center came up on in the month of January this year, and my first day was 9th of Jan. So I'm about to complete 6 months of practicing as an allergy specialist at my center. So initially the patients would always think, oh, you're a special doctor who does allergy. We didn't know allergy is a thing. So that's when I realized that, okay, I also have to make people aware about this specialty and that they have allergy, and it's not just cough and cold, and it's not just skin itching, it's not just food sensitivity which will go away, and it has to be treated, it has to be managed. It's not just antihistamine tablets that they require. So now apart from doing skin prick testing, I'm doing immunotherapy, biologics, I'm doing spirometry, and I'm hoping to even progress more. And I would thank the entire MedTrain team for giving me this. First of all, the training, and then second is the opportunity to speak today about how it has been. And if there's one message I'd like to leave you all with, is that setting up your own clinic or service in a niche field like allergy might feel overwhelming to begin with. But if you see a gap, knowledge gap or a gap in care, then don't wait for someone else to fill it in. Be the person yourself. And you have to start small, stay consistent, and let your patients be your biggest motivators. Yeah, with this, I would end my message. Yeah.
Thank you. Thank you.
Thank you.
Thank you, Dr. Mosam. That
Thank
must
you.
be really, promising and encouraging for many of them who are wanting to set up a
Yeah,
allergy practice
yeah.
now. Yeah. So, anybody or any more who's wanting to? Yeah. So, Dr. Bala and all other faculties, anything else that you would like to say?
I think it's really nice to see our
Alumni.
students as alumni doing so well.
Isn't it?
And as you said,
Yeah.
so many of them have taken up allergy, and a lot of them have become teachers now, and they are teaching themselves, and spreading the knowledge, and nothing can be more satisfying than that. So it's really nice to see. Thank you.
And we would also want to continue to do some such connecting programs with our alumni so that they reconnect with themselves also, not just with us, right? Yeah. Dr. Bala, can we call it for a night?
Yeah, sure.
Yeah. Thank you.
Thank you.
Thank you all.
Thank you.
Thank
Good
you.
Thank
night.
you all. And thank you all for your active participation.
Thanks for joining. Yeah.
Thank you, sir.